Okay, I want to talk about this interesting case of nephrotic syndrome. So this was a 29-year-old male who presented to the emergency department with 3-day history of bilateral leg swelling up to his thighs. His initially his face and hands were swollen, but those had improved before he came in without any intervention. He denied other symptoms, including shortness of breath or chest pain. He had no cough or fever. He had no hematuria or decreased urine output. He had no sore throat, abdominal pain, rash, myalgias, or any other symptoms really. He had no history of this problem. He did not take any prescription medications, no street drugs, no alcohol, but he did smoke cigarettes. He has a family history of hypertension, and he endorses normal food and fluid intake. He didn't just chug a couple of gallons of water or anything like that. On physical exam, his temp is normal at 98.2. His heart rate is okay. His blood pressure is elevated, 161 over 112. Again, no history of hypertension. His normal respiratory rate and normal oxygen saturation. He was generally well appearing. His neck exam was normal. There's no JVD. His cardiovascular, respiratory, and abdominal exams were normal. Most importantly, he did not have any adventitious lung sounds that were clear to auscultation, no murmurs. His extremities, he had a normal facial and upper extremity exam, no edema there, but he did have bilateral lower extremity, hitting edema up to his knees with some more subtle edema at his thighs. In the ED, we established an IV, we got some blood work and sent a point of care urinalysis, which was clear yellow urine with 4 plus proteinuria. So ultimately, this young man was diagnosed with nephrotic syndrome. This is characterized by proteinuria with edema, low albumin, high blood pressure, and high lipids. Complications of nephrotic syndrome include infection, thromboembolic events such as DVT and pulmonary embolism. You can develop CKD, but rarely do you get acute kidney injuries. Risk of acute renal failure does go up with specific pathology or etiology, including minimal change disease, HIV nephropathy, and renal vein thrombosis. On the right here, we see an illustration of what nephrotic syndrome can look like. This is characterized by edema. That's the most important clinical presentation. Proteinuria, so you have protein in your urine. You have low albumin because you're peeing it all out. That's the protein. You have high lipids or high cholesterol. And you have hypertension, which is not listed. And that whole picture comes together to cause glomerular damage. I'm sorry, that whole picture comes together insinuating or suggesting glomerular damage. Differential diagnosis includes cardiac, renal, liver failure, hypothyroidism, pulmonary hypertension, lymphedema, venous insufficiency, deep vein thrombosis, thrombophlebitis, trauma or history of surgery on the lower extremities, medications, for example, calcium channel blockers, pregnancy, obesity, and prolonged standing. Causes, the primary causes with sort of an intrinsic renal problem include in order focal segmental glomerular sclerosis, membranous nephropathy, minimal change disease, and membranoproliferative glomerulonephritis. All of those are a mouthful. So there are a lot of secondary causes. I don't have them all listed here, but some of the more common ones would be diabetic nephropathy, amyloidosis, and systemic lupus erythematosus. Evaluation is initially made with blood work and either urine showing proteinuria, but a definitive diagnosis is made with a renal biopsy. Management typically involves loop diuretics. You want to pee off all of the excess fluid. And adults tend to respond slower than children. They're less responsive to the diuretics. In the case of minimal change disease, you'll initiate prednisone, and there are other agents that you can use as well in steroid non-responders. On the right here is a flowchart for children presenting with nephrotic syndrome. Kind of complicated, but if you want to pause it and follow through, it basically comes down to, are they really young? Is it a genetic problem? They're not. Do they have atypical features suggesting something else? And then you risk stratify by age of under a year, 1 to 12 years, and over 12 years, and that kind of drives your decision making. In the case of our patient, he was diagnosed with nephrotic syndrome. His blood work showed a low serum protein and low albumin, but otherwise normal. Nephrology saw him in the hospital or in the emergency department where he was started on furosemide. He was seen in clinic a few days later where he had improved dramatically. He did eventually have a renal biopsy, which showed minimal change in nephrotic syndrome, so he was started on steroids. And 3 key points about nephrotic syndrome. It's characterized by the presence of proteinuria with edema, hypoalbuminemia, hypertension, and hyperlipidemia. Patients present with peripheral edema, and diagnosis is initially made with the clinical presentation combined with proteinuria and eventually with a renal biopsy. Treatment involves loop diuretics and sometimes steroids in consultation with a nephrologist.